Hello, welcome back to the podcast number 2, part 2, tech versus clinician. Here we have me as a physio again, but this time I'm going to be leading on the questions. And we have Hansla over here, our hand therapist.
Yes, sir.
Yeah. You ready to get into it?
Let's get started.
Okay, so we're going to start off again. We're going to be doing questions, ChatGPT, and clinician. All right. And let's see how we get on with it.
Yeah, it's my time to find out if I keep my job.
Yeah. Let's go. Okay.
I didn't realize how much pressure this puts on you.
I know, right?
I know, going in blind.
Oh, it's always scary going up against tech.
It really is.
Because you know they have such a massive knowledge base, huh?
Yeah, and as we found out, they're very precise with their answers as well.
Yeah, you better be. Oh, we're going to be doing things a little bit different over here now, okay? Because we don't have the same style of questions from CAPR, or Canadian Alliance of Physiotherapy Regulators. OTs and hand therapy is quite a specialized field. So because it's such a specialized field, it's hard to find sample questions. So we managed to find them from a hand therapy website where they people use them for exams as study questions, basically. And we're going to put Hansla and ChatGPT up against them. What we'll be doing is we're going to actually give ChatGPT a picture sometimes and a case study or just the question. And we're also going to be giving Hansla the question and the picture as well. And they're going to both have to figure out what's going on in the scenario.
Yeah.
Yeah.
So quick fire style, figure out what's going on.
And we noticed from last time, Chat tend to give a lot of clinical reasoning with his answer or its answer, sorry. And we're gonna ask Hansla to do the exact same thing. Yeah. All right.
I hope that doesn't make it harder. We're so used to just doing our clinical assessments quick, without having to explain ourselves too much. So this will be really interesting.
Yeah, 20 minutes in and out with the patient, and don't really get time to do the clinical reasoning side of things. But here, you're gonna have to demonstrate that. So
put it on.
Get you under a spotlight over here. If that wasn't extra pressure for you or not.
I've got my pen, got my paper.
Yeah, that's an added bonus.
I can make notes.
All right, let's go. Okay, so here's the picture. What type of splint would you say this is, and what diagnosis might it be used for?
Okay, can I have a quick look?
Yeah, of course.
Okay, so it's keeping the hand held quite precisely neutral pronation, supination at the moment. That splint is generally used to just keep your hand in this position to stop your hand from turning either way, and that is generally used if you have an injury to two of your ligament structures, as it were. One is your DRUJ, which is in the middle, or it could... Hey, sorry, I'm fighting it.
I need to see the answer.
Oh,
I don't even know if he's right.
And one is for DRUJ, and the other use of it is for your TFCC, because any amount of movement puts a lot of strain on those two ligaments because your bones are always shifting and moving around.
For those who don't know, what is the TFCC?
It's a ligament structure on the pinky side of your finger that connects your fifth metacarpal. Well, one attachment is from fifth metacarpal to your ulnar head, and there's various multiple attachments throughout your smaller bones within the hand. And essentially, it just stabilizes things. So when you're pushing stuff, when you're lifting up of things, it distributes the weight evenly amongst the ligaments.
That's crazy how big of a splint that is.
Yes.
You have to make those.
That's a big job. Oh, yes, we do that. We do that within our session. But generally, people are casted. It's only very specific times where we would want to put them in a plastic splint as opposed to a cast.
Yeah, it makes sense, for conservative management methods.
Yes, if you have a surgeon who works very, very closely and the patient comes out of surgery and they want them to be splinted immediately, then yeah, absolutely.
Oh, so you would do this right after surgery as well?
You could do, because if the consultant would rather have them in a splint and not a cast, and if the consultant, the surgeon and the hand therapist are working right next to each other, then yes, absolutely. However, generally, because our departments are quite separate, we work in therapies, they work in surgery and theatres, they would send them to plaster room, which is...
Yeah, it's like right next door, so yeah.
Exactly.
It wouldn't make sense just to come directly.
Yeah, and it makes more sense that way.
But you could technically do that.
And I suppose it's one of those things where if a patient knows they can take it off, after a few days they probably will take it off, because they are cumbersome, they're not easy to wear, and it's plastic. You're wearing a piece of plastic on your hand the whole time.
Yeah, it's not comfortable. No one likes plastic and wearing that.
No.
Okay, let's put Chat through the test now. So let's ask Chat. What was the question exactly again? So what type of splint is this? and what diagnosis might it be used for?
I'm really interested to see how it diagnoses the picture because there's so much going on in the picture. How would it know if it's a thermoplastic splint or if it's a cast?
Let's give it the picture.
This will be interesting.
Let's load it up. Answer. Okay. This appears to be an orthosis, commonly referred to as a splint. Specifically, it looks like a long arm splint, which extends from the upper arm down to the wrist. Yes. Such splints are typically used for a variety of reasons, including post-surgical immobilization, stabilization of fractures, protection of ligamentous injuries, and the management of certain inflammatory conditions, such as severe sprains or after the removal of a cast for a broken arm.
Yeah.
So this one says it's for a broken arm.
Yeah.
Or for a ligamentous injury. For yourself, you said it's TFCC.
Yes.
Yes, which is also
it's a ligament.
It's a ligamentous injury.
If you have
now let's see what the actual answer is.
Oh, okay.
We haven't checked the actual answer yet.
Yeah. So ChatGPT was quite broad about things. I just want to say, so I just want to point that out.
Oh, you didn't mention what type of splint it was.
It's called a sugar tongue.
You call it a sugar tongue. Let's see what chat said.
Sugar tongues generally extend to further up to sort of mid bicep.
This splint might be cannot be determined solely from the image. It could vary from fracture to fracture. Be able to specifically diagnose based on thorough examination of patient history. So even chat didn't mention what kind. So chat also didn't mention what kind of splint it was. It did mention it was for a ligament, but it couldn't specify as to what type of injury.
Yeah.
You mentioned the right type of injury, but you mentioned the wrong splint. It was actually I don't even know how to spell this. Say this. Muenster splint?
Okay.
Muenster splint?
Okay.
Can you read that? What does that say?
Yeah. Muenster splint, apparently.
Yeah. For TFCC injuries.
Oh, okay.
DRUJ injuries, and to avoid forearm rotation while allowing elbow motion.
Yes.
Which is what I believe you said as well.
Yes.
But chat didn't mention that.
No.
Okay. Well, I'm actually going to have to give this to you. It was close, chat had it, but it couldn't diagnose it correctly.
No.
And it couldn't tell us what splint it was. So definitely 1 clinician, chat 0.
Yeah.
Let's go.
You know what? I'll take it. I'll be finished now. That's it. I'll take it.
You wish, wouldn't you?
I really would.
You ready for question number 2?
This
one's a little bit more challenging.
Yeah.
Okay. So I'm going to show you this x-ray. I want you to tell me, what do you think it is?
That's a finger.
Okay.
Oh, there's quite a lot of subluxation on that finger, on the DIP, so your fingertip joint.
Okay.
It looks like the bone is wearing away. The joint space is completely narrowed. This looks very arthritic, actually. Like the subluxation itself could be trauma. It looks like it could be trauma because you can see little avulsion. There is that osteophytes. However, just the degeneration on that joint, it does look like it's sort of arthritic in nature.
Okay, so you think
I would say final answer, osteoarthritis.
So you think it's OA?
Yes.
Regular OA.
Regular OA.
Okay. Yeah, those joints look pretty
yeah,
messed up.
Devastated, don't they?
Yeah.
You know what? That's not the worst ones we've seen.
Yeah. So just osteoarthritis, huh?
Mm-hmm.
Okay. Let's give chat the same question. I'll give you guys the answers right after.
Of course, to differentiate, you would want to find out the history, whether it was traumatic, recent history of trauma, repeated movement, that's more degeneration side of things.
Okay.
Social history.
You definitely want to know a lot more about any case study, but you're only getting the image.
You're just eyeballing it.
It's all sometimes, a radiologist is only given that.
Yeah.
But you're not a radiologist, are you?
No. Oh, we don't have all this time in the clinics.
Mm-hmm.
No, we do, because our computer can be slow.
Tech versus clinician. Clinician is one, clearly. Tech stopped working.
Clinician's faster, apparently.
Let's refresh the page. Let's see if that works. Oh, the internet's gone. Oh, no. Oh, no. This is chat being crazy. All right, guys. We're back from our technical difficulties. Sorry about that.
That didn't take long at all. That was about 1 second.
Oh, yeah, totally. So we clearly know that clinician definitely wins.
For now.
For now.
For now.
Until you go off sick.
Like chat did.
All right. So now we're going to ask chat what it displayed in the x-ray. And let's see what it comes back with. Give it a second.
Computing.
All right. Sorry, so we're gonna have to go back to your answer. What was your answer again?
I said
Osteoarthritis.
osteoarthritis
Yes.
from the looks of it.
Yes. Okay. So chat comes back saying that appears to be an X-ray of a finger showing a fracture of one of the phalanx, the bones in the fingers. Bone fragment is displaced, which means the pieces of the bone are not aligned properly, referred to as a displaced fracture.
Okay.
And the fracture here may require medical intervention to realign the bone fragments and to immobilize and splint or cast. So they would end up coming to you eventually.
Yeah.
And sometimes could require an ORIF, so a reduction in internal fixation.
It'll be interesting to see what the actual answer is.
So the actual answer, both of you were actually wrong. So that's 0-0 for both of you for that question.
Okay.
But you guys are 1-0 for you, so it's 1 out of 2.
What's
The
that?
answer is sorry, I'm keeping the suspense here. It depicts an example of osteoporosis as evidenced by the bone deterioration.
Interesting. Interesting.
Well, there we go. We have that one. So let's move on to the next question now.
Right.
Okay. I like this question. They call it a slippery slope. Here's a slippery slope.
It always is in healthcare.
Let's see what a slippery slope is. Okay, so they're asking us in this question, and I'll show you the picture in a second, what type of surgery was performed and what is occurring in the yellow circle?
Oh, that looks like a carpal tunnel decompression surgery. That's a big old scar there, right in the middle of the palm.
Mm.
Now, it's held, there's no stitches in there, so it's either they were taken out or it just was steri-stripped together. Generally, there are stitches.
Mm-hmm.
But it's got steri-strips now, meaning that at some point they were replaced, but they look very clean. And you can see the dry skin build up. Actually, that's an old scar right now, but the scar looks a bit yellow in the middle, and there's a lot of redness around the area as well.
Mm-hmm.
So it seems like there could be signs of infection, early signs of infection.
Yeah, that's what I would have said as well.
Yeah. I mean, you can't tell how dry or wet the wound is. You can't, feel the temperature of the wound, but if there's redness like that and yellowing like that, it's very likely going to be an infection there.
Yeah, as a clinician, I agree with you. 100%.
So carpal tunnel decompression and possible infection.
Yes, I agree. Let's see what chat says, and then let's see what the actual answer is. Now we're putting both of us to the test here.
Yeah. You would want to contact the on-call doctor or send them to the medics that referred them to you.
Yeah, 100%.
Or to the GP at the very, very least to get some antibiotics.
No, you can definitely go to the GP, 100%.
Yeah. If you can
get through to them.
That's what I was about to say, if you can get an appointment with them.
Okay, so it's not letting me copy the question. Oh, technical issues again. What type of surgery is this? There we go. Let me copy the question, copy the image. Here.
I can ramble on about that injury for a bit more if you like, once it's loading, or that surgery even. The big old scar across the palm is there.
There we go. It uploaded. We don't need your answer anymore.
Okay.
We don't need you to talk anymore. That's okay. All right. The image appears to show a post-operative wrist with a circular area highlighted, likely indicating a specific area of interest or concern. Yes, okay, we know that, chat. That's what we're asking.
Thanks, chat.
So it talks about the redness and what could be swelling or an irregularity in the skin, possibly suggestive of post-operative complication. Very good. It's what we said as well.
Mm-hmm.
Of an infection, a reaction to the surgery, or localized swelling. Very good. Okay. It's difficult to say precisely what type of surgery was performed without more context. However, given the location of the wrist, it could be related to a number of procedures such as carpal tunnel release, fixation of a wrist fracture, or another type of reconstructive surgery of the bone, nerves, or tendons in the wrist. And so, because of the redness, swelling, yellow circle, and signs of infection, it would likely be accompanied with pain, warmth, possibly fever. So it's telling us to go to a healthcare provider to get antibiotics and clean the wound out, basically. So it's exactly what we were both agreeing on, and what you said.
Yeah. Sounds about right.
And let's see what the actual answer is. So carpal tunnel release, which is what both chat and you said. Very good. So what's that? That's 2 for 3, 1 for 3. Oh, wow.
It's not bad.
No.
Not bad.
Not
of
bad.
course, goes without saying, history of trauma. Was there any fractures before?
Mhm.
Any
It was
chronic
also
ligament tears.
Yeah. This one also mentioned about the wound and needing to go for, yep,
Yeah,
definitely
yeah,
antibiotics and all
yeah.
that. Okay. All right. Now let's move on to the next question. Okay.
Okay.
So here we go. We have another surgery. So what does it look like is going on in this hand over here?
Oh, that's a lovely old scar there. Not scar. The scar question, isn't
Yeah,
there?
yeah, yeah.
That looks like it was a release of some sort.
Okay.
I mean, the location where it is at the moment, it could be a Dupuytren's release, which is just bunching off the fascia in the hand, or it could be a trigger finger release, one of
Okay.
the two. So, but just the
What
positioning.
makes you think that?
Because trigger finger generally, when they do release it, if it's occurring, if your finger is clicking.
What is considered trigger finger for those who don't know?
A trigger finger is a what they call a tenosynovitis, where there's inflammation within the pulleys that you have that hold everything down within the hand. Too much rubbing, a small nodule forms, and every time that nodule has to pass through the pulley, it just catches every time, and it just clicks. I know it's a funny motion, but that's how we describe it to people.
Yeah. I was gonna say nothing. I was gonna say nothing. Okay.
Yeah. Pause. So what they do is they release the pulley. The swelling isn't catching anymore. I'm not going to do the motion again. So they release the pulley so it stops catching, and then your finger stops clicking. So you know what? Out of the two, I would lean more towards the trigger finger just because of the location.
Okay.
And if they're doing a Dupuytren's surgery, then it normally is a zigzag down the finger that they normally do. So yeah.
So you think
answer.
it's a Dupuytren's or a trigger finger release?
Yes.
Okay. Now let's ask chat what it thinks it is. Okay. All right. Copy the question.
I'm really surprised at how good chat is doing, even though it's not a specific diagnostic AI tool.
Yeah, it's not. And not only that, it's got to, it's got to analyze the picture as well.
Yeah. It's doing really, really well.
Yeah. All right, let's take a look. So, chat's come back saying this image shows a hand with the sutures of the thenar region.
Yep.
Yeah. Rounded area at the base of the thumb. The presence of sutures suggests that the person recently underwent surgery in that area, of course.
Wait, did chat say base of thumb?
It did say base of the thumb. Yeah, why?
That's
definitely not the base of the thumb.
That's not the base of the thumb. That's that's across your palmar crease, your
base.
distal palmar crease at that. So,
but it says such as the repair of a tendon or ligament, removal of a cyst or a mass reconstruction following trauma.
yeah.
Now the hand appears to be in the early stages of post-operative healing, indicating that intact sutures. Doesn't seem to be excessive redness, swelling, which could be signs of infection or complications. Surrounding skin looks healthy. Positive sign of normal healing. It gives you, good clinical reasoning over here as to what it's, what it observes.
Yes.
Okay.
Yeah, that sounds very good. It could be a ligament, a tendon repair. Sorry. Yeah. But going by what is most commonly seen.
But yeah, because it's not asking you for a specific diagnosis. It's asking you what's going on in the scenario.
Yes.
Right.
Yeah.
Yeah.
I think we as clinicians we are so sort of almost diagnostic focused. Where,
sometimes we can be.
Sometimes
we can be, but it's not always good to be, is it?
Yeah. I mean, we recently discovered I mean, it's a great saying, isn't it? Not we recently discovered, we practice this every day, but it's a great saying. You don't treat the X-ray, you treat the patient.
Yes. Aww. Yes. You don't treat the diagnosis. You treat the patient.
Yeah.
Very good. Yeah. Absolutely correct. Person-centered care here.
Yes.
Okay. So the actual answer is this is status post trigger finger release, and the patient is having somewhat of a reaction. It might be an early infection or stitch reaction. Patient is 2 weeks post-op and will need to have sutures removed and possibly will need antibiotics. I'm just going to go back to chat and just see, because I think it said it wasn't a reaction.
Okay.
Which could be signs of infection or complication. Doesn't seem to be excessive redness or swelling.
No. So it's a bit difficult because we don't know how old the surgery was. If it was, say, done 2-3 days ago,
I think
then it's quite normal to have that amount of swelling and the redness and the molting and such. However, if it's 2 weeks post, sometimes you can still get swelling. It really depends on how you heal. You can have the same surgery on both hands and they all heal differently. So.
To be honest, I didn't even pick up the fact that it was infected. It didn't look infected to me, and I actually agree with chat. And you didn't say the same.
No,
I
don't.
You were right about what type of surgery it was. Chat never mentioned that, but it also didn't ask in the question. So I think this was a very bad question, to be honest.
Okay,
I
well,
think it was a bad
good,
question, so I'm going to give
good,
both of
good.
you guys the
Tut,
points,
tut,
to be
tut.
honest, because chat did answer the question exactly how it needed to be, right? And you just managed to go the extra step and say what kind of surgery it was.
Yeah.
So, good on you. You know, so you both get that point there. Because obviously, chat's only going to give you the answer of what you've asked it. It's not
Yeah.
going to go beyond that.
It's not going to go past
Sometimes
that.
it will. Sometimes it'll give you way more than
Again, it's only as good as the information you are able to provide it.
Exactly.
Yeah.
Exactly. All right. So, what is wrong with this radiograph?
Oh, another radiograph.
There we go.
Okay, let me zoom in a little bit. Oh, there is a massive gap between the scaphoid and the lunate. You don't have to squint very hard to see
For
this.
those of you that don't know, it's just small little bones just here in your wrist. A couple little bones.
So one just at this point here, you can feel the one bony point of it. The other one, if you do this and follow your middle finger down, 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 you come into a gap. Now that gap is about, I'll say, this wide. Now that doesn't seem like much, not at all actually. However, for your body, which works on very precise things, that's a huge gap because that ligament, it stabilizes alongside other ligaments within the hand. It stabilizes everything, much like how I said earlier about needing to push up.
Yeah.
Anytime with that ligament, when you are pushing or taking weight onto the palm of your hand, that's when it sort of is the most effective. So there's a massive gap, and also I could see a little fragment right next to the scaphoid, which is the bone right in there.
So what do you
in that
think
little
it is
box.
then? Do you think it's an avulsion fracture?
I think there is an avulsion fracture there. However, I think the scaphoid lunate
Is torn.
torn.
So it's an avulsion of the scaphoid lunate. Then.
Yes.
Is that what
Yes,
you're
yes,
predicting it is?
yes.
Okay, I like that. It's good.
Either
good
a
clinical
scaphoid
reasoning.
lunate avulsion and tear, or scaphoid lunate tear plus avulsion of possibly the scaphoid or maybe a distal radial head. I couldn't see too clearly on that radiograph based on the quality of that.
Well, I'm trying to ask chat, and we're getting technical difficulties again. Sorry, guys, our Wi-Fi is just really, really poor today for some reason. I just don't know why. So we're gonna go back to the question. I had to refresh the page.
I've actually seen quite a few of them. We had a patient come through, and he came and he said the GP looked at the X-ray and said actually there wasn't too much going on, so they're gonna send them to hand therapy. I pulled up on the radiograph, and there was about a 4 millimeter gap between the scaphoid and the lunate. Generally, you expect about 1.8 millimeters, anything less than 3, essentially, or even less than 2 millimeters or 2 point something millimeters. However, that gap was so obvious that it just jumped out at you. But again, if you don't look at loads of radiographs specifically of the carpal bones, then you are not gonna know.
Yeah, well, we work fracture clinic in our trust, in our NHS trust, so we definitely see a lot of that.
Yeah, we see a lot. Yes.
So you have a
very, very easily missable. Very easily missable. Very easily done, but just by falling on the hand or just doing repetitive movements.
It doesn't want to.
You know what? Just I know chat's not loading, but I'm pretty sure I got that one right.
Oh, I definitely think you got that one right. Just waiting for chat now to load the answer. There we go.
Yeah.
So the image, it's saying severe. Yeah, it's a wrist, including the radius and ulna, the carpal bones of the wrist. There appears to be abnormality with the alignment of the carpal bones, which suggests a carpal dislocation or a fracture that has resulted in a dislocation fracture. Kind of injury is typically a result of trauma to the wrist, which can bones cause significant pain and dysfunction. In normal circumstances, the carpal bones should form smooth, regular arcs when viewed on X-rays, but in the radiograph, it gives way too much of an answer.
Way too much. Layman it for me. You should tell it to layman it for you.
Diagnosed by a healthcare professional. It is also possible that have multiple and complex. It's not. Give me a diagnosis.
No. I just told you no.
I can't provide a medical diagnosis. That's good. At the moment, yes, chat can't. But let's see what would
possible?
be your best guess.
I like how you have to sort of walk around the subject for it to give you the right answer.
Carpal fracture or dislocation, particularly that mentioned misalignment of the disruption of the carpal bones, and your trauma wrist. So you were very specific. Carpal dislocation implied the bones of wrist and normal. Okay.
I'm more specific than chat. I am
No, it's saying to
surprised.
go to an orthopedic surgeon. It won't give us an answer.
Yeah.
You know what? That's good at the moment because we don't want tech to be doing that yet until,
Yet.
obviously,
Until it's better. A
Yeah.
lot better.
Yeah.
Yeah.
So it's not giving us an exact answer as to what it is, but it is saying there is a fracture and there's a misalignment within the wrist.
Yes.
And you did mention that misalignment as well. You just mentioned scaphoid lunate.
Yeah.
And
very
over here
specific.
in the answer, it says the exact same as what you were saying as well. Okay. And it also goes on and says it's a positive Terry Thomas sign. I don't know if you know what that is.
Yeah. That's essentially if your scapholunate is wider than 3 millimeters.
Okay,
Yeah.
fair enough. Okay, now we're gonna move on to the next one. So, what would you say this diagnosis is?
That's a hand.
That's a hand.
That's a hand. That's a really good start. The other fingers are bending, but the ring finger is just sticking out, meaning that it's lost its ability to flex by the looks of it. It's lost its ability to flex at the middle joint by the looks of it, so your proximal interphalangeal joint. And it looks like the tendon that helps you pull that, it's the FDS. It feels like that's not attached anymore. That's what I think is going on because all of the other fingers are bending, but this one's not bending.
Mm.
Yeah. So FDS injury or
What's an FDS?
it's a good question. It's a tendon that when the muscle contracts within the hand, it pulls your middle joint bending.
What is it? What is it called?
Flexor digitorum superfundus.
There we go. I was like, everyone's not gonna know what that is.
Well, and they'll know the full name of it. It's a tendon that helps you bend the middle
That's a
joint.
good point. They won't know the.
Yeah.
Sorry, guys.
Yeah.
I was being pedantic.
It's fundus superficialis.
Now let's ask chat.
Yeah.
Let's see what it says. Oof. It's always taking forever. Come on, chat. We're running out of time.
It's processing a lot of information, I guess.
Always.
Always.
Okay, while it processes, let's see what your next answer is then. Oh no, there we go. Posturing of the fingers, where the little and ring fingers are curled towards the palm. This type of finger posturing can be associated with several conditions, but with proper medical history, physical examination, it is impossible to give a definitive diagnosis. Curled fingers is Dupuytren's contracture,
Amazing.
a condition where the fascia, the fibrous layer beneath the skin and the palm fingers thickens and contracts, causing the finger to bend inwards. Another possibility could be neurological condition affecting the muscles, or it could be related to a musculoskeletal issue like arthritis causing joint deformities. For an accurate diagnosis and appropriate treatment, appears to consult a healthcare professional. Always directing to a healthcare professional is definitely necessary. Moment, clearly, guys. Clearly, it's definitely necessary.
Yes.
Let's see what the answer is.
Actual answer is
FDP avulsion.
FDP.
Flexor digitorum profundus.
Oh, FDP. You know what?
Of the ring finger.
You know what? That's actually right because actually you can see there's some flexion at the middle joint. It's the fingertip that's not bending. Oh, very good. You know what? I'll knock a point off for that one. Yeah.
That's fine. Well, guys, we're running out of time over here. So we got over here one last radiographer question. It's Fracture Mania is the title of it.
Fracture Mania.
So what type of fracture would you say this is? Oh, let me hide the answer. There we go. Go ahead.
Oh, a very bad one. That's
Yeah, that one's a bad one, huh?
If someone came in to my clinic and I saw that in their history, I'd say good job. You did a very, very excellent job of breaking that. Oh God, there's a lot going on. Hey, both the big wrist bones are fractured, so your radius and your ulnar, it seems almost mid-shaft. Like a heavy impact that a weight just dropped on there, or the full body weight went onto it. The ulnar is completely out of whack, so the middle joint here, so your DRUJ, which we mentioned earlier, that's completely gone out of whack. That's torn.
What type of fracture is it?
The name of the fracture. I can't remember the exact name of the fracture. I can tell you exactly what's damaged.
What's fractured?
Your radius and your ulnar.
Okay.
And your distal radius ulnar joint is
done.
It's
okay. So there's a lot going on here.
Yeah.
Let's see.
Mid-shaft distal radius ulnar fracture.
Okay.
Would likely need an ORIF to fix.
Yes, you definitely need an open reduction.
Internal fixation. Yes. Probably an ORIF in the middle, and then probably pinning the DRUJ together for a bit to hold it in place.
Oh, definitely.
Oh, yes.
All right. And now we ask chat. So, clear example of a bone fracture. It looks like it's a long bone of the arm, likely the forearm, visibly break, angulated and displaced. complete fracture of the bone with broken distinct parts, pieces not aligned, displaced fracture, additionally angulation, broken bone, my angle, require orthopedic intervention. It also says ORIF.
Yeah.
History and physical requires confirmed fracture in terms of the appropriate treatment plan. So it's also saying go to a healthcare professional.
I think we're seeing a theme running here.
Yeah,
That's
with
a
chat.
running theme here. Yeah.
It doesn't like giving us a diagnosis.
No, it really doesn't, huh?
I think it's just erring on the side of caution here.
Yes.
Yeah,
Avoid litigation. Avoid every
Definitely,
litigation bit you can.
But I know it has the answer in there because it mentioned all the right things. Okay. Now, when you were saying what type of fracture, the name of it, it's called a Galeazzi fracture.
Galeazzi.
There we go.
Mm-hmm.
I have no idea how to pronounce that.
Yeah.
Which is a fracture of the distal radius with a dislocation of the subluxation of the distal radial ulnar joint.
Oh, yeah.
So you're right. You were on the money there. And chat also mentioned forearm and a fracture and displacement and also required, intervention.
Chat mentioned
and the right
human body.
intervention. So it did give the right answers, but didn't give it the right specific diagnosis.
No.
So when it came to giving us the answer, it's 0. But when it gave the right clinical, treatment advice, that was good. So that's a positive to look at when it comes to this.
Yeah.
When it comes to tech, there's a lot of advantage that healthcare can, benefit from when it, we can integrate chat into healthcare.
I think it's more supplementary as opposed to a replacement. It's very much supplementary. I know that they've started to do tests with running MRI scans and CT scans, and getting AI to diagnose them, which will be much, much faster than waiting for a radiographer to report on the X-ray.
But again, it's not diagnosing. Remember, we always have to remember they're all CDSSs, right? They're clinical decision support systems.
Yeah.
They're there as a support system.
Yeah.
They're there to provide a report, but in the end, it still requires a radiologist to approve it.
Yes.
And it requires us to overlook it from human eyes because it's still very rudimentary in a sense.
Yeah.
It's an infant.
No one is willing to say my AI will be 100% successful and 100% sensitive to everything you throw at it, because it's not going to be. There's trial and error. AI has to learn on its own as well, looking at hundreds and hundreds of X-rays and people manually inputting what the fractures actually are, or having a database to look at to compare
100%.
to. Yes.
But it makes things more efficient. Like
does.
apps, if we were able to upload these images into apps and AI were to tell us and possibly give us appropriate treatment advice, all right? Or at least send it to a clinician and the clinician can improve that treatment advice. That
like a triage system.
Yeah, exactly. Implementing it in triage. It makes things more efficient in a sense.
I think like one of the questions is a slippery slope, because what if it misses something?
No, but that's always why a clinician in the end needs to be the one that approves what happens and what goes out to the patient.
I think
so. It's a decision support system. It makes things faster because then we don't have to write things. Those admin side of things we don't have to do.
At what point do you decide you have to double check chat's work and not double check chat's work? Is it creating a double work for the individual involved whose job it's trying to supplement?
But we would always have to double check it. Let's say we have like 1,000 X-rays, right?
Of course.
Now it's written all the reports and all the possible things that it has to go through. Instead of us having to go through those, possibly coming up with looking through them, finding the diagnosis, writing it all out, it's already done that for us. We agree with it. We say, okay, fine, confirm.
Yeah.
That would make it a lot faster. It makes it more efficient in a sense.
No, it does.
And there are softwares out there that do that. That has been implemented in the NHS.
You know what? If anything, it can help you triage, supplement your triaging service, essentially, where it comes in and it's rather than someone sitting down and logging through all of the diagnosis, X-ray and such, it just auto sorts it out. This is leg, this is going to hand, this is going to ribs, spine, brain, such and such, and then you can just be disseminate to different teams as opposed to having one dedicated 100%. Team that needs to sit down with 10 doctors and decide which fracture needs to go to what place.
And that's only one way we're thinking.
And that's only one avenue of it.
That's there's so many different avenues you can implement it. That would make things so much more efficient. So rather than actually thinking of it, it's taking over our job. It's actually just complementing our job.
And you know what? So far we've done case studies and we've done radiographs and looking at pictures and such. It'll be interesting to see how it does against doctors who work in primary care actually. Who have to go off of illnesses and symptoms, and multiple conditions present with the same symptoms, and it's not as clear cut. It's not as clear cut as an X-ray. So stay tuned for that.
Hopefully, and stay tuned, and I'm hoping you guys enjoyed that.
Yeah.
Catch you guys next time.